So we're going to talk about BLS resuscitation, and we're going to summarize this chapter. All of you have had CPR or BLS. The American Heart Association now calls healthcare provider CPR as BLS, or basic life support. So you've all been certified in BLS. So we're going to go through this and summarize, and this will be a good place to study, possibly for the test, as well as your BLS provider manual. So again, we're going to summarize your BLS provider manual. The principles of basic life support were introduced in 1960. So CPR or BLS isn't new, but it has been refined quite a bit over the years. BLS is the cornerstone of everything we do in cardiac arrest. We know from research that without high-quality CPR, and there is a definition for that, without high-quality CPR, the patient typically will not survive. So it is important that we provide as high quality of CPR as possible. So that's a lot of what we're going to talk about today. Every 5 years, the International Liaison Committee on Resuscitation, or ILCOR, reviews resuscitation science and makes suggestions for revision. The American Heart Association and the American Red Cross and other organizations in the U.S. and internationally are members of ILCOR. And they get together not just every 5 years, but periodically and review the science. The American Heart Association has said that when there's a significant change in the science, they will revise their guidelines as necessary. But the ILCOR as an organization reviews and revises their guidelines every 5 years. So typically what you will see is the American Heart Association and other organizations will revise their guidelines and make new materials about every 5 years. However, the American Heart Association has, since the previous guidelines came out in 2015, they have made some updates to scientific processes, or I'm sorry, not scientific processes, but made some changes to the BLS process due to the research that's out there. So the elements of BLS, our focus should be on preventing cardiac arrest by managing the airway, breathing, and circulation. So if you find a patient who has a pulse, our goal with this is to prevent that patient from going into cardiac arrest. If a patient doesn't have a pulse, then the emphasis becomes compressions, airway, and breathing, or CAB. So with a pulse, it's ABC, airway, breathing, circulation. Without a pulse, it's CAB, compressions, airway, and breathing. It's very important to understand that any patient who is without a pulse or is not breathing is very time critical. If someone isn't breathing or doesn't have a pulse, every second that they have is very critical. And you see from this this drawing here, the time is very critical. From 0 to 1 minute, the heart becomes very irritable, which means it's subject to a variety of heart rhythms. Again, whatever underlying problem the patient is having can cause a variety of heart rhythms in and of itself. But anytime the heart is without oxygen, it becomes very irritable and can tend to have very erratic heart rhythms. From 0 to 4 minutes, brain damage is not likely. So that's the time that we want to get to people. In more urban EMS systems, many fire departments aim to get to the patient within 4 minutes so that then they can start good high quality BLS. In rural areas, that is more of a problem because we typically have more volunteer fire departments. There's longer distances. There are not as many people to assist with bystander CPR. So in rural areas, that is more of a problem. But the goal is to get to the patient and begin BLS within that 4-minute period. From 4 to 6 minutes, brain damage is possible. Again, this is a time when we have some time. The sooner we get to the patient within this 4 to 6 minute interval, the better off they'll be. But we do have some time in this 4 to 6 minute time frame to save the brain. But it's important that we get to them as soon as possible. From 6 to 10 minutes, brain damage is very likely. At this point, it is unlikely, especially toward the end, once you get up to that 8, 9, 10 minutes and longer. Brain damage is very likely. We still attempt to resuscitate, but just understanding that brain damage is likely. Now, that can be varied. That may not be catastrophic. It may be something as simple as someone can't remember short-term things or something like that. But again, it can also be catastrophic. Over 10 minutes, we consider this time period as irreversible brain damage. So if you look at response times in rural areas, oftentimes they're right about that 6 to 10 minute time frame. So that does affect outcomes from the final result of being able to have people walk out of the hospital. If there's no pulse, we immediately start CPR. High quality chest compressions are considered at a rate of 100 to 120 per minute. The ratio of 30 compressions to 2 breaths for adults, ratio of 30 compressions to 2 breaths for adults, child and infant, with one person providing those compressions. So it is important to remember the term high quality CPR. It's very difficult to provide high quality CPR anytime you're trying to move the patient, and this includes in the back of an ambulance. So I'll mention this again just a little bit later. So the American Heart Association has established a CPR chain of survival, and this is actually an entire system of care. As you can see here, the first link in that chain is recognition and activation of EMS. And this recognition and activation needs to be as soon as possible after the event. So again, in rural areas, that's not always the case. The next link is immediate high-quality CPR, followed by rapid defibrillation if necessary, and then with basic and advanced EMS, and then once in the hospital, ALS and post-cardiac arrest care. So we know that, we typically talk about links of a chain as when something bad is happening. So if you break one of these links, something bad typically has stopped. In this case, we're talking about these links of a chain that we want connected. These links have to be connected and have to be connected in the right way in order to have the best chance of survival. So it is important to have that rapid recognition and activation of EMS, immediate high-quality CPR, followed by rapid defibrillation, followed next by basic and advanced EMS, and then post-cardiac arrest care once we get ROSC, or return of spontaneous circulation. So we're going to briefly review the steps of BLS. The first thing you want to do if you find someone who is unresponsive or appears unresponsive is tap and shout. If you know their name, shout their name and tap them on the shoulders. Again, we want to avoid any pain-causing processes such as sternal rubs and this sort of thing. But we're going to tap and shout, and we're also going to call for help, especially if we're by ourselves. So that's very important. If you're not responding as part of your emergency response agency, that you call for help so that you get somebody there to give you a hand. The next thing we're going to do is check for pulse and breathing. This is done simultaneously in no more than 10 seconds. So we're going to check for a pulse with adults and children at the carotid artery, which is in the neck, runs down the side of either side of the neck. And we're going to check for pulse and breathing at the same time. When we're looking for breathing, we're looking for rise and fall of the chest. So if we don't see rise and fall of the chest, we're going to assume they're not breathing. And then if we don't feel a pulse, we're going to assume that they don't have a pulse, and we will start high-quality compressions. If there's no pulse and they're not breathing, have someone call 911 and have them get an AED. It's important that, if you're not with your emergency response agency, that you tell someone specifically to call 911 and to get an AED if there's one around. Obviously, most people in their residences, their homes, are not going to have AEDs. However, in businesses, there's a lot of businesses and public places that do have AEDs. So it's very important to get into the habit of having someone tell someone to go call 911 and to get an AED. If the patient does have a pulse, but they are not breathing, we're going to provide rescue breaths every 5 to 6 seconds. And these rescue breaths can either be with healthcare providers, we suggest you do not do mouth to mouth. It should be mouth to barrier device, or if you're with your emergency response agency, it can be with a bag valve mask. Immediately after this, we're going to begin high quality chest compressions. And this is composed of a rate of 100 to 120 per minute, a ratio of 30 compressions to 2 ventilations, at least 2 inches in depth, and let the chest fully recoil after each compression. So as you see in the diagram here, the person providing compressions is over the top, is kneeling at the side of the chest, is over the top of the victim with their arms straight down. So the idea is that their arms are pushing straight down, you're not pushing over to the side, and that pressure on the heel of your hands is right over the sternum or the breastbone. We don't want pressure on the ribs. It is likely that even with proper chest compressions, especially with older adults, that you will hear some popping and cracking. And if compressions are done properly and there's no underlying other disease processes such as osteoporosis or these sorts of things, it's likely that you may break some of the cartilage between the ribs and the sternum, but you should not be breaking actual bone, the bone of the ribs. Next, we want to apply an AED as soon as possible. The picture of the AED here is shown with what the Harrison County Fire Departments have, but all AEDs work very similarly. And so it's important that you get to know your AED that you have at your agency or your business or wherever you may be doing CPR at. The key with AEDs is you follow the instructions, follow the pictures, and you turn it on before anything happens, and you follow those verbal instructions. Next, we're going to open the airway, and this can be done one of a couple of ways. And next, I'm going to show you better diagrams, but this diagram indicates that the reason we need to open the airway is because when someone is lying on their back and they're unresponsive, the tongue will fall down and block the airway. The tongue is simply a large muscle, and so when we are unresponsive, muscles relax. So the tongue will fall back, and you see the yellow in this diagram, in the first diagram on the left, that the tongue, the pink area, is covering the opening to the trachea or the windpipe. As we open the airway and we flex the head back, you see that it naturally pulls the tongue up off the back of the airway, and that passageway is then open both from the mouth and from the nose. And in these diagrams, we actually see two different maneuvers. We have the head tilt chin lift maneuver, which is simply putting one hand on the back of or on the forehead, another 2 or 3 fingers on the chin. We want to make sure we stay on the bony part of the jaw and chin, not in the fleshy area under that. And we simply flex the head backward, and this opens the airway. If you suspect that the patient has some sort of head or neck injury, there is another procedure called the jaw thrust maneuver. And the bottom part of the jaw, or the mandible, moves very easily, especially when someone is unresponsive. So you place your hands on both sides like the picture shows, and you simply push up on the where the mandible and the maxilla meet, which is the hinge of the jaw. You simply push up, and you'll see the chin rise forward. This actually does the same thing. It's a little bit more difficult, and it takes you holding your hands there that entire time that you're doing ventilations. But it does allow one person to open the airway, and then it would need another person to actually give those breaths. Once you get a pulse back, it is important to, number one, you have to monitor that patient to make sure that they keep a pulse. It is frequent that once someone has achieved ROSC, or return of spontaneous circulation, that they will become pulseless again. So it's important that we monitor that patient continuously. But if we are not yet transporting the patient, they should be put in a recovery position. And this is when the patient is adequately breathing and has a pulse but is not conscious. So if you get ROSC and they are not breathing, which is common also, they still need to be on their back so you can ventilate them properly. Otherwise, if they are breathing and have a pulse but are not conscious, we put them in the recovery position. And this allows any secretions or vomitus from the mouth to flow out and not to flow back down into the airway. And this would apply to any patient from any cause that would be not be conscious but be breathing and have a pulse.